There's no cost to be doing this part of that program. This is something that you could add instantly, immediately to your practice, regardless of doing the insulin therapy. This is just something that people are missing out on. And this is the whole point. This package and program that we put together it's absolutely perfect for a practice because of the fact that it does everything that you need to do. It takes away all the worry that Medicare is going to come back and do something to you when you have all this compliance.
That's very wise. Especially these days, it's important to have all your ducks in a row for any insurance you build, right? All right, welcome to the Medical Entrepreneur Podcast. We have two very special guests today on the podcast. We have Tom Saridis and Paul Clements on today. And today we'll be talking about some new opportunities to help patients with diabetes.
Adam, thanks for having us on your show.
Yeah, thanks, Adam.
Oh, my pleasure. I know there's so many people that are suffering with diabetes, and it seems like people are having more and more issues with insulin resistance. Tom, my understanding is that you and Paul have a system that you guys have that allows basically physicians to help those people with diabetes and or having difficulty with their blood sugars. Can you tell me a little bit more about the system and kind of how it works?
Sure. So, Adam, what we found was the standard of care for diabetes is failing the patient. And it's no fault of anybody. Diabetes is overwhelming the medical community based on numbers, right? You know, the American Diabetes Association is saying that 1 in 2 are going to be one type of diabetic by 2030. You know, pre-diabetic, type 1, type 2, type 1.5, type 3. And then the biggest one is a lot of people are walking around undiagnosed. Right. So what we found was the biggest concern that diabetic patients have, or the correct terminology, people with diabetes have, is they feel that they're not able to get the standard of care. They're not able to get the support. You know, with a chronic ailment like diabetes, the problem is it doesn't go away in 3 months. And it's not like an acute injury. You know, you walk into your ER and you've got a fractured bone. They put a cast on. They tell you to take it easy. Don't put any pressure on it. Elevate it. And in 6 weeks' time, come back and see me. I'll take the cast off. That patient's compliant rate is going to be tremendously higher than a patient with a chronic ailment like diabetes, because they know that if they do things correctly at the 6-week mark, boom, life went back to normal. And this was an episode in their life. Diabetes isn't an episode. Diabetes is something that you will live with and have to manage the rest of your life. Unfortunately, with the amount of people with diabetes that are, you know, in society, there isn't enough medical professionals to be able to manage them. The current standard of care, if you get to see your specialist 4 times a year in 15-minute increments, you're getting after a whole year, you get an hour's worth of patient management. That's not enough to manage an illness that requires 24/7. It doesn't go away. You don't just take a pill when you're in pain. You don't just take a pill when you're feeling lightheaded, right? With diabetes, it's everything you eat, everything you drink. You know, the enemy is in the fridge. The enemy is in the grocery store. The enemy is on TV, right? We've learned that food is no longer just a fuel. Food has become a part of socializing. Food has become something that's entrenched in our society. Birthdays, bar mitzvahs, weddings, funerals. Oh, you know what? Everybody's gathering around food. Well, that poor diabetic patient is constantly having to be on guard and monitoring themselves 24/7. So when I looked at what the problem with diabetes was, I identified that if we can take that chronic ailment and treat it like an acute. And what I mean by that is see the patient frequently, provide the necessary tool they need, education. They need nutritional guidance. They need dietary information. They need to better understand how the medication works, when they have to take their medication, right? And by doing that in 3-month increments, we're able to keep the patient motivated, engaged, and they want to start taking control of their diabetes, right? So they come in, our program starts off with, it's 26 visits in the first 13 weeks. By doing that, we're entrenching them with, every time they come in, it's a 2-hour visit. So twice a week for 2 hours. That means they get 4 hours of face time with the medical professional. Even more important than with the provider that they're engaging with, there's a diabetic that's in the chair beside them. So they start to build on the positives that each other is doing and realizing that it is doable. It is achievable. I can control it, right? So when they come in, they get weighed, blood pressure check, discussion on what they're eating. Each and every one of our patients gets a CGM after a couple of weeks of being on the program. And it's really just encouraging positive behavioral results. And, at the 3-month mark, we draw labs again. We do another diagnostic ANS test, which we use for baseline to show improvement and, risk scores. And what ends up happening is A1Cs are dropping. Insulin resistance is dropping. Chronic fatigue improving. Better sleep patterns, motivation, brain fog. A person with education understands how to handle it and what to do next. So it's been a joy to see how well our patients do.
Did you want to show maybe some of the patient progress reports, stuff like that? I don't know if you want to show some of that, Adam, on there, but I mean, you can even walk through some of them that you're seeing.
Yeah, I was actually just pulling those up.
Yeah, there's a snapshot of all the, Tom has definitely taken the time to put progress reports together to show exactly what's going on in the practice there, so we can understand the dynamics and actually the excitement of what people are seeing, results just in the first 13 weeks, let alone a continued program throughout the year.
Yeah, it's very common, Adam, when we talk about patient improvement. There you go. It's very common to see this within our patients. It's very common for our patients to have similar results. And I just, the one thing that my staff does very well is we preface them coming in. This isn't a magic pill. If you're not prepared to put in the beginning, we tell patients, we're going to lift 90% of the weight. You got to lift the 10%. As the program goes on and your frequency of visits diminish because you're more in control, we're only going to do 10% of the work. And then you're going to do 90% of the work. Right? But the whole goal is they have to be engaged. We've had to let some people go because they come in here and they think that by having our program, they're on their phone ordering their Uber Eats as they're getting ready to go home. They're ordering, the worst types of foods. And, and they're like, wow, but I got my treatment. I'm good to go. And that's the problem with, I feel what's happened is, let's say somebody has a headache. They take Tylenol, right, to mask the pain. Well, they haven't really done anything to treat the root cause of what caused the headache. So is the pain still there after 4 hours? Is it because of dehydration? Is it stress? Is it, being overly tired? If you're not addressing the root cause, then you're just going to constantly be masking with another pain relief medication, right? And that's what happens. A lot of these patients are, they're taking their medications and they're now developing a lot of side effects. But even further to that, what ended up happening is the minute they miss their dose, their blood sugar spikes, right? So it's telling me that the medications do a very good job at artificially lowering some of the markers that diabetics look for. You want to lower your glucose level. You want to lower your A1C. But really, what happens if you take somebody off that medication for 15 days? If they're using that medication that's, on the standard of care as a crutch, what happens when you take that crutch away? Have they learned to balance on their own? 99% of the time, Adam, I'm going to tell you that the answer is no. That's what we see for patients. And, a lot of times, with a chronic ailment like diabetes, prior to us developing our diabetes management program, they were managed by multiple specialists. Patients are over-medicated. Kidney filtration, one of the things that we factor in here is their GFR rate. Kidney filtration improves, right? So it's not rocket science. It's being able to spend the time with the patient and give them the attention they deserve, to give them the tools they need. The Microburst insulin infusion protocols we use, what ends up happening is we give very minute doses of insulin while they're here for their 2 hours as part of the treatment plan. And what ends up happening with that is because you're giving such small trace amounts back into the bloodstream, what ends up happening, Adam, is the pancreas identifies it's there and then realizes that it's not enough and it starts to try to produce, right? When you're subcutaneously injecting 40, 50, 60 units of insulin, that's a huge dose. Your pancreas identifies it, sees there's enough, and then gets even lazier. So what are you doing in theory is you're teaching your body to expect the external insulin, and the pancreas doesn't have to produce any. So it's kind of counterproductive. The insulin is doing the job that the body's supposed to. And instead of figuring out a way to have the pancreas start working again, subcutaneous insulin injections aren't doing that. Whereas when you're giving a person a 0.25 dilution rate in a 19.75 syringe of saline and insulin, the pancreas sees such trace amounts, identifies it, and realizes it has to start to produce more in order for it to bring it up to the quantity it needs, right? So that's part of why medications diminish, because your body starts to work the way it was supposed to. Now, look, I don't want to lie to anybody and tell them that we're going to make you a 20-year-old, an optimum, pancreas and optimum metabolism. But what ends up happening is it starts to do what it can. So instead of having to take 40 units of insulin before bedtime lock acting, our goal is to bring that down to 10 units and then continue to monitor the patient. This isn't an anti-pharma kit. This is manage the patient with the minimum amount of medication they require while the patient is engaged in doing what they have to, right? Every patient gets a CGM. Think about when a patient goes to see their doctor and the doctor says to them, after you've had a meal, I want you to prick your finger. And if your glucose is like 300, I want you to take X amount of units. Okay. Well, we know one thing, Adam, you're a doctor, so you're going to understand this. All foods that we eat spike our blood sugars to different heights and at different times. Things like soft drinks give us almost an immediate spike in our glucose level. Would you agree with that statement?
For sure, yeah.
Foods that are carbohydrates will take longer to convert that carbohydrate to a sugar. So you'll still get, let's say, the same spike as drinking a Coca-Cola, but it might take 45 minutes to an hour to get that glucose to that level. Would you agree with that statement?
Mm-hmm. Yeah.
So what happens if a patient has a Coca-Cola, pricks their finger, and takes 20 units? They prick their finger 5 minutes later and they take their 20 units. What happens when they finish eating? They prick their, after they've had a bowl of pasta with some protein, and the blood sugar doesn't spike to that 300 and they only take 5 units. You're constantly over or under medicating yourself. Is that a fair statement? Because it's not an exact science. It's a range, and the range has a time element to it. And, how much exercise did you put in that day? How is your body going to process that sugar? Is it going to convert it to energy? Is it going to be sugar that's just floating around in the bloodstream, increasing the glucose level? So you're basically constantly doing this. An average diabetic, when you look at their graphs through their CGM, it's constantly doing this because over medication, under medication not at the right time, medication too late. Patients are then going low. Patients then need a cookie. Well, the patient that went low, isn't it very simple to say, and correct me if I'm wrong, Adam, I'm not a doctor. Isn't it simple to say that a patient that just took insulin that now is going hypoglycemic and is dropping to the threshold, wouldn't you say that it's because they took too much insulin?
Most likely, yeah.
So what ends up happening is then they're taking a cookie, and that cookie's now going to bring them back up. The thing again, guess what? Based on what I was told, I got to take some more insulin.
Okay. Let's just, to make sure that everybody's kind of following along, let's take a step back. So basically what you're kind of seeing, if I can summarize, and correct me if I'm wrong, is that basically the traditional way that we manage diabetes for most patients is to give them, especially when they get to a certain level, give them a lot of medications and insulin to take at home.
Correct.
And the problem that they have is they have insulin resistance is what's led to the diabetes. And most of the time, based on sliding scale insulin, they're overcorrecting. It's not optimal. It's not designed, like where our doses are far off, which cause even more insulin resistance, right?
Correct.
And then you have this kind of yo-yo effect where you have the average diabetics up and down and up and down, and it wreaks havoc because of that. And so the answer that you've developed essentially is to have people come into the clinic and get these microburst infusions,
Correct.
which are more accurate. They're not overdosing, not causing insulin resistance because
Correct.
it's a huge dose. Instead, they're actually training the body to essentially start to, quote, like lift the weight, as you said in the beginning, train the pancreas to release insulin properly, et cetera, and not shut down their own endocrine systems with these huge doses of insulin.
Correct.
Is that kind of how it works?
100%.
Perfect.
Yeah. You've done a very good job at summarizing it. So then what ends up happening is when the patient does leave Adam, they're better versed. They've got a CGM, they can check, a CGM is like watching a movie. Pricking your finger is like taking a picture. What's going to be more accurate? Trying to put 4 pictures together or watching a movie for the day? That's the difference. The CGM allows us to get real-time data. Even if in some models there's a 10 or 15 minute delay, I can start to see my trends. I can better understand, right? So the CGM has become a very valuable tool in the management of diabetes. And we incorporate that CGM, for people that might not know, it's constant glucose monitor. When you incorporate that constant glucose monitor, I'm not a diabetic. I wear it because I want to understand what my patients are seeing. When you incorporate that within the program, now you've got a person that is well-versed, has the tools they need, understands what they need to do. So when you look at my patient progress reports that you've got on screen right now, look at their fasting glucose when they came to us, 301.
Yeah, let's walk through these in case somebody can't see the screen. So here we have a 58-year-old female patient. This is October 16th here to January 14th. So October of 2023 to January of 2024. This person began with an A1C of 11.3, now down to 8.8. So that's a huge decrease in the A1C. We have the glomerular filtration rates roughly the same, but it was good to start with. But look at this fasting glucose level. Initially 301 fasting glucose down to 130. And that's only in 3 months with 14 infusions. That's very impressive. We have insulin resistance here. Looks like it wasn't measured initially, but it looks like the ANS risk score.
Yeah, no, I wasn't measured initially, but 18 is now within range. She's no longer resistant.
Exactly. So I think, what's really interesting is that we see, and just to finish this off, like our ANS risk score has actually, looks like it, I'm not sure, went 64 to 71%. So it looks like it improved slightly.
That's right. There's a 7% improvement in health risk. So you're diminishing risk for cardio and you're diminishing your risk for heart concerns.
And you can see here that the patient actually was able to drop 2 different medications as well.
Yep.
That's a huge win. So basically, just to kind of take a step back again, essentially by doing the Microburst insulin program, you're able to contour the treatment for patients much better because you're seeing them more often. You're able to give them, a different standard of care. And because the patients themselves are not using huge doses of insulin that cause this like wild up and down ride, you're able to basically get this, these kind of results here. Let's see if we can look at another one. Here's another one that's a 57-year-old female. Started out at 8.2 with an A1C, now down to 6.6. So A1C's decreased by 1.6 total. The glomerular filtration rate from 95 to 110 has improved. We got a fasting glucose initially of 153. 4 months later, 91. We have basically a insulin resistant risk rate, or insulin resistant rate of 100 down to 21. So that's a huge win in terms of insulin resistance. Very impressive. And so you can see here that this is another great example of somebody in just 4 months who basically has turned themselves around from being heavily insulin resistant to very low level of insulin resistance. And then we have another one here. This is a 72-year-old female. This is a 3-month kind of test here. And so at baseline, the person had A1C of 14. 3 months later, down to 11. Glomerular filtration rate was good. And actually, we have 7-month data here. Sorry, I didn't see that. This person here was 14.3 at initial. At 3 months, they're down to 11 on the A1C. And then at 7 months, they're down to 10. So that is a huge, dramatic drop. I mean, most people with diabetes, their insulin resistance continues to increase.
Correct.
Here you go. Your A1C is already responding. That's very impressive.
Right.
You can see here, this, even look at the C-peptide. Wow, 7.8 initially down to 2.42. Very impressive. And our fasting glucose, which is a great measure, I think, 285 initially down to 135 in 7 months. What a win.
Correct.
And then, insulin resistance also shows that it's improved. And medications went down from 3 medications to 2 medications. And then it looks like at 7 months, they didn't have any medications. They were just on injectable insulin.
Correct.
So got them off all the meds, better situation, less insulin resistance, taking less medications, patients healthier, happier. All the metrics are very good. These are very impressive results. And then we have another one here. This is a 63-year-old female. And so here, this lady had an A1C of 12.2 down to 10 in 4 months. Glomerular filtration rate slightly improved, indicating her kidneys are improving. Her fasting glucose, 368 fasting glucose. That's pretty high. Down to 253 within 4 months. Incredible. And then you have, and also looks like here, I was able to reduce several medications. So we got 1, 2, 3, 4 here, down from 1, 2, 3, 4, 5, 6. So we lost 2 medications.
So it's a reduction of, it's a removal of 2 and then a reduction in the remainder. So think about what we were able to do. We've dropped A1C, less medications. Patient is more educated. They're managing, so their quality of life is up. Risk for hospitalization is down. They know what to do when they get up in the morning if the blood sugar is high. They're not walking around. They also have access to the clinic. Right? And when somebody is seeing you twice a week, Adam, you're answering all their questions. What I like to say to doctors is, we're not an or, we're an and. Meaning, continue to work with your internal medicine, endocrinologist, primary care, and come into our treatment, our clinic, and let us assist you in one single facet of what's wrong. We're not here to take care of your bumps, bruises, scratches, headaches, earaches, dizziness. No, we are a diabetic management clinic. We do one thing and we do it very well. Right? So we're giving back to their doctor a patient that's better health, more knowledgeable, chronically not going to complain. We act as customer service. Our nurses and our MAs are taking all the questions and answering them. So when they go to the doctor, it's an efficient visit. It's a refill of prescription. It's a decrease in medication. And it's basically just a checkup on how are you doing? And I'm going to tell you that the majority of our patients tell their doctors at that point, we're fine. And then they'll come back and see us in a couple of days. Right? So now that doctor doesn't have to worry about, okay, this person's going to complain about their foot, their leg, their diabetes, they're constantly in pain. Improvement in neuropathy when you have the blood flowing better, right? So, gabapentin, decrease in, it's a world of difference from a patient that comes in here that feels that they're at end of life. They've given up to their diabetes. They're coming in here and they're telling us they walked a few miles yesterday. They're telling us that they're better, their clarity, their brain fog, their overall mood is better. How do you not call that a win? And I can't say to you that it's one thing or another. It's something that you have to do in conjunction, right? You can't just think that an insulin infusion is going to be the magic pill if you're not providing the patient the education. You can't say that the education is going to work if you're not showing them what the insulin infusion is doing. If you're not giving people ideas on how to eat. My staff here doesn't provide recipes. It's very frustrating. A quarter teaspoon of salt, a half tablespoon of this, make sure you have this seasoning, make sure that you cut the meat this way. We provide grocery lists so that they can go out and get what they need and then prepare them in ways that they want. What we do is not rocket science. We provide empathy, compassion. We're in healthcare. What's the biggest phrase there? The word care. We're in healthcare and we do it very well.
Wow, that's good. I think, for a lot of people that may be listening to this, we see the results that you're able to get with this. Can you maybe explain how this might be something because what I've been kind of amazed about is for a lot of physicians, the issue they have is they just don't have time, right? They're already busy. They're doing a lot of stuff.
Sure.
But this program that delivers these results can actually be run by just essentially a staff without requiring the physician, just physician oversight.
Correct.
And basically sounds like it's a kind of a plug and play, because if you already have an existing practice you're running, you can essentially add this program onto it to better manage the diabetic patients, whether you're primary care, even if you're pain management, dealing with a bunch of patients with neuropathy, very common. You can add this program onto your practice and basically deliver these amazing results, help get people met off of drugs, get their, A1Cs better, their kidneys better. This sounds like it's a huge win. Maybe could you talk about how someone might be able to use this program or what steps could they take to basically build something like this for their own patients?
So we have a model of what it looks like to incorporate into a conversion. So a conversion model is a clinic that is currently operating and is, I challenge any clinic out there to tell me they don't have diabetic patients, right? So what ends up happening is with pain management, patients are coming in, you're treating them for the pain and you're showing improvements, whether you're using shockwave, laser, what protocol you're using, especially for neuropathy. Patients going home. Fantastic. Pain is going to come back because what have we done to address the root cause of the neuropathy? In the majority of the times, Adam, the neuropathy is brought on by the diabetes. So you have a patient that's coming in, you're treating them for the one symptom, but you're not getting to the root cause. So we developed a way to not only benefit the patient, but a fantastic financial model that allows the office to generate a profit while treating the patient. And there's no shame in having profit in healthcare, right? And you're providing a service that's much needed out there, is reimbursable by insurance. The other component to this is, like you mentioned, yes, we don't expect doctors to be sitting out there and babysitting and managing the patients. The program was developed around having a nurse practitioner and medical assistants to deliver. As a doctor, you're doing the initial intake, you're doing the 3-month follow-up. But you've got patients coming into your clinic that are diabetic and they're leaving because they came to see you for a reason X, Y, and Z, which we're all tying back into diabetes. Now we're saying we've developed a business model and protocols that will allow you to not only work on the neuropathy, but also work on the diabetes, because that's what is triggering the neuropathy. That's what's triggering a lot of the subsymptoms. I think Paul can go into the side of it where we talk about the numbers and that, but this is not something that's going to require a physician to breed a twin of himself because he's got to have 8 hours on the floor. It was designed as an efficient model to be delivered by nurse practitioners.
Awesome. And I just wanted to show just a couple of things that you also had sent over, which was, I want to show this article that you sent here. This here is an article from the International Research Journal of Public Health, just showing that basically using this Microburst insulin infusions actually have been shown to basically help, wound healing time in diabetic patients significantly.
Correct.
Which I thought was very interesting. So often we see diabetic patients, many times they have wounds that are not healing. That's very common. And yet, basically by having this program available for your patients, you're able to not only, heal them kind of long-term, but also in the short-term, help them with even their wounds, which is like a huge problem that is currently happening in what I call mainstream healthcare. There's so many patients have wounds that are not healing. They're traveling around, going to wound care clinics that may or may not be helping them. And it's just like, this is actually treating the actual problem, which will help them heal.
Correct. Chronic foot ulcers on diabetics is a problem. And I read somewhere, and please don't quote me, I might be off, but it's something like one amputation is happening in the United States every 97 seconds because of diabetes.
I believe that. That's very common.
We're very excited about what we're doing with our patients. With Paul's help, we've introduced this, let's call it clinic in a box. It's very simple. We'll train the staff that's going to be delivering it. We'll support you. We've developed a comprehensive marketing plan that assists you in getting the patients. But to be honest, when we first start out, most of these clinics have the diabetic patients there. They're walking through the door. So you're introducing them to another service that's going to benefit them. So it's when I built my clinics, I had to start from cold turkey. I had nothing, right? We had to get our first patient in. We had to get our first insurance contract in. We had to get all the accreditation from the state. These clinics are up and running. Their lead time and their profit generation is exponentially shorter than what I had to live through and go through. I'm also probably in one of the toughest markets in the US, the South Florida market, with 160 something different insurance programs and capitated care and managed and all risk. And, we're finding that, even within this market, we have the ability to succeed because diabetes is not going away. There's no magic pill. And to top it off, it's exponentially growing. When we looked at diabetic rates, Adam, 15 years ago, everybody had an Aunt Trudy, an Uncle John that was a diabetic, right? And, he's a diabetic. Now, when you look at it, it's no longer, it's not a far stretch for you to think of at least a half a dozen diabetics, right? And it's no longer a disease that affects people in their 60s and 70s and 80s. It's, we're looking at diabetes going backwards. We're seeing 40-year-olds and 30-year-olds, right? Type 2 diabetes, quality of food, abundance of food. It's affecting everybody and it's getting worse and worse. And if we look at, what is the true endemic in medicine, I would have to say that diabetes is probably, top three. I don't want to even tout our horn and say number one. We're going to say it's top three concerns that are happening right now.
Absolutely. Well, I have on the screen an EOB from Medicare, and I don't know whether you want to comment on it or Paul does, but here's an EOB that you guys provided, just to give you an example of like what Medicare can reimburse here of a patient. And so we have this artificial patient, Jane Doe. I imagine this is probably taken from a real patient. You changed the name.
Correct.
So I can see they have like remark codes and everything on it. So somebody actually built this out. But you can see here that basically it looks like you have a few different charges here. It looks like, I'm not sure if this is for how long this is for, but basically it looks like the total net here.
For a single treatment.
So for a single treatment, it looks like it's generating around $247. Does that sound about right?
That's correct. But patient portion, don't forget the 20% copay.
Yeah, it's like $61.
So let's call it $300.
Yeah. And this is something that can be done essentially with oversight. So if you have a staff, then, you can basically run these clinics, and it sounds like people are coming twice a week.
Correct.
For these infusions initially, and they decrease over time, right?
Correct. Now keep something else in mind, Adam. The nurse practitioner isn't dealing on a 1-to-1 ratio. So while she's seeing this patient, she's got 3 others in the chairs around her. So that really greatly diminishes the labor of revenue to delivering through a medical professional, right? So there is a strong business model that we built as well that shows a very healthy bottom line.
This is definitely something that can at least at the bare minimum pay for itself, and looks like it's highly profitable, especially if it's 3-to-1 ratio like that.
Yes.
4-to-1. So basically you can 4-to-1 ratio. Wow, even better. Basically, it sounds like to me like you can basically use this is a great addition to basically, it's not only revenue generation, but you're also significantly helping your patients. And you actually have a solution because mainstream medicine is just offering more and more drugs, more and more insulin, which is producing more resistance, which is causing a lot of these issues, Here's one. This is from Blue Cross Blue Shield. Obviously, the names have been changed. And it looks like here with Blue Cross Blue Shield, it's $305.65. This is one visit, right?
Yeah, no copay.
Perfect. Yeah, I mean, this is awesome. So this indicates that these are profitable enough that they could easily be seen. This is a kind of a rare situation in medicine where you can actually get paid to basically help somebody in a way that's actually handsome, versus many times in medicine, we're having to sacrifice to help people. And so I thought it was really interesting.
So when it comes to this program, what we're seeing is from what so I'm out front talking to all the doctors and the clinics all the time, trying to figure out, they're always, as well as I do, they're always looking for ways to help their patient, but at the same time, help drive revenue and, be efficient on both ends. And what Tom did with just the insulin therapy alone is excellent. But what you start doing and what you forget about is the fact that when these patients are walking in, as Tom said, they're getting their blood tested. So you have labs right away. Now the next thing that you're doing is you're either doing ANS testing, which now is a billable program as well. And then also And then you go into the therapy. Once you've shown medical necessity confirmation that they do have the issues that they have, now you can start to go into the treatment therapy. And then the next thing that happens is now after they're done, Tom lines them up with a CGM, sets them up with a Libra 3 type device. And now you're able to monitor that patient on a monthly basis, which is a billable component. And then not only that, but now if your provider is diabetic credentialed or certified, you can now start doing counseling with that, which is now also a billable portion of that. So what ends up happening, and once you get this established, the next thing that really starts to kick in is punch biopsies for tracking, let's say, that diabetic patient. You need to really verify and confirm what's happening with that patient's neuropathy. And so what ends up happening is punch biopsies have been very common to use to confirm also how that neuropathy is traveling, the severity of the neuropathy, that type of stuff. So it complements the ANS testing. So that is also a very profitable type of program that is very conclusive, and it really adds compliance to the mix, right? The biggest issue that we've had right now and what's happening out there in the industry is clinics are taking on portions of this program, but they're not completing the program. And what will end up happening is when Medicare starts asking you, well, what are you doing? They're going to look at your plan as a whole. They're not going to say, oh, you did microdosing insulin. Okay, great. That's a great therapy. Okay, so how did you confirm that? Well, we did. We took some blood tests. What you mean you're going off of what you just listened to what the patient's saying, or how are you doing that? So they're not adding the ANS testing for confirmation. They're not doing the skin biopsies in order to verify the severity of the neuropathy that they're treating. So what ends up happening is this program that we've designed is complete from start to finish, soup to nuts. So what ends up happening is if you ever do get questioned by Medicare or Humana or any other insurance company out there, you now have the file full that can show exactly from beginning to end on why and how and what information you got in order to treat that patient. And that's what's being missed out there. When I'm talking to my clients out there, these other practices out there, it's literally almost 100%. None of them do everything. They always do pieces, right? So what ends up happening is you'll have some of these from a business aspect. You'll have clinics that are saying, well, I can't get paid off of this TM flow or this ANS testing. Well, what are you doing? I mean, so what is your plan when you're testing that patient? What are you doing? It ends up being a lot of times when they get it denied is the simple fact of the matter, they don't have a treatment therapy. They're just basically sending in a diagnostic test saying, oh, well, we talked to the patient. So therefore, here's this diagnostic test that we build them for. That's not a plan. They don't want to see that. They want to see why you did it and what was your plan after you did it. And what has been created through this program, when we've had documented in our pro forma, is start to finish. As Tom said, when that patient walks in, we know exactly what we're going to do with that patient. Starts with the blood. We're going to verify A1Cs, and then it's going to, yep, you do have issues. Then it's going to be ANS testing. We're going to set that baseline. We're going to find out what's going on with them from galvanic skin response, the whole 9 yards on what ANS testing can do. Now you're verifying, and now you can set a plan for that patient. Now you go in, start to do the treatment therapies, and now you follow up on the back end with monitoring and counseling. But then also at that 13-week mark, now you can go back in, do some more ANS testing, do some more punch biopsies to verify and now track progress of what's actually happened with that patient. That's what the insurance companies want to see. That's what Medicare's want to see. They don't. People are so scared of doing all these things. Well, if I do it too much, then I'm going to get a clawback and all this stuff. That's BS. If you're doing what you're supposed to be doing as a clinic, as a doctor, as a provider, they're not going to mess with you. You're basically saying, how can you argue with what I'm doing? Especially, how can you argue with what Tom's doing when he can show progress reports like he has? Now, this article you have up here, it specifically talks about punch biopsies and small fiber nerve density testing on what it can do for verification. And it actually complements your nerve conductivity tests and things like that. And so this is a very overlooked diagnostic test that could be done in a lot of practices. In fact, the pain docs are very much underutilized in this particular test. So we work with specialists. I have a specialist. She's a neurosurgical PA that's known all over the country, that from a compliance standpoint, she can walk into a clinic, show you how to do this test and these programs, and make your office absolutely as compliant as possible. So if you ever do get an audit or something from a Medicare or insurance, you're prepared. And so I think the biggest problem with clinics that are getting audited and stuff, they're not prepared and they're scared. If you're prepared, I know many clinics that have been prepared that are doing procedures that others might say, oh, I don't do it because I'm scared. Well, the reason you're not doing it is you're not prepared. I know many of these guys that are doing these type of procedures that have gotten audits, that have been prepared, and everything is fine. They're paid, and now they move on and do business like usual. You're not, and you as a provider, and you know that you've been audited many times. If you're not prepared, anybody could get, no matter what procedure you're doing, anybody could get audited and claw back on whatever because you didn't have the proper diagnoses and the compliance
Documentation.
And the documentation to show and verify why you did what you did. So this program is designed to do that. We're basically prepared for any type of audit that might come on, because other things that are talked about when it comes to microdosing insulin, even though it's been around for 50 years, obviously you have medications that have kind of taken over and everybody's using medications. So this has kind of got set by the wayside, and they are only using it typically for when that patient's blood sugar would be spiking above 500, right? And now that's a weekend. Tom talks about this all the time, hospitalization. So they're basically saying, well, you should only be doing microdosing on an inpatient basis. Well, if you look at how it works, that's not necessarily true. I mean, obviously, if it's spiking and you need to be brought back down, sure, they bring you into the hospital, and then they'll hook you up to a drip, and they basically of insulin, and they bring your blood sugars back down, and then they send you home. But guess what? You just got a $13,000 to $15,000 bill. So this is something that done, yes. Is it done in the hospital? Absolutely. But this is something that can be shown when monitored and done in a microdosing program, can be very beneficial to the patient on an ongoing basis. It doesn't have to be an inpatient type program that is done.
Perfect. I think the thing that I see, especially with this, is like, small fiber neuropathy is often overlooked. And so even with these punch biopsies, it really helps to identify is it neuropathy large or small fiber?
Yeah.
That's going to change how the treatment is.
Yeah.
But I think what is really great for a lot of people is that you guys kind of have a whole system figured out. You've been able to build a system that only requires physician oversight, and essentially execute these treatments for patients, which help them significantly. You can see from the data. On top of it, you're actually able to do the testing, which is helping to prove that, hey, we're on the right path. Our microdose insulin program is not only benefiting you with your labs, but we can see that, hey, you have small fiber neuropathy, and over time we can monitor that and watch it improve, make sure that our treatments are helping you to improve that. And so it's kind of like a business in a box, I guess, you can bolt on to an existing practice. Is that right?
Yeah. When I'm talking to these clinics, I'm basically saying, listen, if I'm a doctor, I'm looking at, this is such a base of a program, of a clinic, that everything else can be built around this. Because from a marketing standpoint, I'm the business guy, right? I'm the money guy, right? Tom's got passion. He's the clinic. He does everything there. I look at it from the business standpoint. What are we doing with your practice? How are we keeping the lights on, right? When they're cutting epidural rates down to where you can't, there's no money in reimbursing, a lot of these other areas. What can we bring on that's legit, that is going to help drive more revenue by bringing in more patients that we can now see and have other aspects of other procedures that we can do? This program here, and Tom will tell you, neuropathy and diabetes from a marketing standpoint is probably the best marketing program that you can put out there, because this is going to drive more patients than anything else that you've been a market in the industry. Number one, just from a clinic standpoint on activity of patient activity, this will drive in more patients into your practice than anything. Right, Tom? I mean, when you talk a little about your marketing, Tom, I mean, when you first started doing this, and all of a sudden you created your marketing program where you started doing with just little ads then, started driving in huge amounts of patients to your practice, 40% of which are self-booking, right? And so we'll talk a little bit about, from the marketing aspect, what this could do for the practice.
Patients are ready, Adam, for something that's different in the treatment of their diabetes. They know that if they're just going to go see a doctor again, it's going to be another medication. It's going to be more side effects. It's going to be back to me doing it all on my own. So when we do a message, I do a 15-second little clip. It's a very simple message. And it goes usually, are you tired of being blamed for your diabetes? Are you told to exercise more and eat less? Are you tired of taking medications that don't work? Are you tired of not feeling good? Come on into Insulinica, Florida for a complimentary 30-minute diabetic consultation and see why we're different. That right there on the Meta platform started generating between 240 and 280 leads per month. We drove the cost per lead down to $10, right? So
Wow.
there is an appetite out there for something. There's an appetite.
Yes, I could definitely see that.
That's what it is. And it was done in a very condensed 7-mile radius. We have 2 clinics, so 7-mile radius around each clinic, and it started generating leads. And it was generating leads with a mere budget of $75 a day. So we know that there's an appetite. And as we've gone, we've continually tweaked the message, right? Patients coming in. The biggest failure we had was being a new company in a new clinic and getting credentialized and contracted with insurance companies. We didn't have all the right providers for our marketplace. But with an existing clinic that Paul's talking about, it makes a lot more sense because they're already credentialized, they're already contracted. Those people are coming through the door. That's the big win. The diabetic patients are sitting in your waiting room. You don't have to encourage them to come in. You have a relationship with them. They're in your database. They're in your EMR. You treat it.
Yeah. So from a business standpoint, this is the best of all worlds, because not only are you doing some great work and great medicine for these diabetic patients and giving them hope again, you are now creating an activity of your practice that you haven't seen in a long time. So it's going to create these numbers that are now going to allow you to generate revenue and then continue to do good work. And so what you're showing us here is basically the revenue that can be generated from some of these practices that are doing punch biopsies. So from a standpoint of, don't tell me that there's nothing out there that you can't do that doesn't pay well, that isn't good work. The punch biopsies are a very good barometer of what's happening with that patient's neuropathy. And it also pays well for the practice. So it pays for itself. So once we come in, if we come in and talk to a clinic, by the time we're done, we're going to show them the pro forma, everything that we do. This is not hypothetical. This is going on every day. What Tom does at a practice, that's our training site, national training site at this point, is done every day. You don't have to call around and find out who else is doing it. Tom's doing it. All right. He's doing it every day. He can show you the numbers. And so this is all real time stuff that currently, these are all updated national numbers that are currently being reimbursed by Medicare and commercial payers across the board. So when you take our whole
these
program,
are pretty significant. I mean,
yes, if you look at that, 1, 2, 3 site, Medicare right now, standard. And I have a lady that I would bring on, Karen Goldenson is like super guru in this side. I'd love to have another program, which is Karen on, talking about the significance of utilizing this program and this diagnostic treatment. And every pain location should be doing this. And if they're not, they're missing out on 2 things: confirmation, they're missing out on medical necessity, policy, and procedure. They need to be doing this, number 1. Number 2, it is significant revenue as well. And so not only is it going to show you how to take care of that patient and set the guidelines.
I was saying, I think you have a really great point, because so often we have people that come in that are diabetic you're treating their neuropathy pain by prescribing medications, which are essentially nothing but Band-Aids, right?
Exactly.
You're giving gabapentin to help decrease neuropathic pain, but
Yeah.
we're not really fixing anything.
No.
But now you have the opportunity to bolt on this practice to your existing customers and essentially have them go through this where you can actually improve the actual problem, which is leading to the things you're treating. So you're actually fixing the root cause. That's very wise.
There's no cost to be doing this part of that program. I mean, this is something that you could add instantly, immediately to your practice, regardless of doing the insulin therapy. This is just something that people are missing out on. And this is the whole point. This package and program that we put together it's absolutely perfect for a practice because of the fact that it does everything that you need to do. It takes away all the worry of that Medicare is going to come back and do something to you when you have all this compliance.
That's very wise. Especially these days, it's important to have all your ducks in a row for any insurance you bill, right?
Exactly.
But more important, I guess, I was looking is like so if I have an existing practice and I have a lot of patients that are coming through that are diabetic, then this is just easy plug and play. What if I don't have a practice? What if I have a practice that maybe I'm a neurosurgeon, for example, and I still run into a few diabetic patients here and there, but primarily I do neurosurgery. Is this something that I could also start up and use the marketing that Tom was talking about before to bring patients in?
That's correct, Adam. We'll assist you in developing traction in your marketplace. We'll assist you in the message that you need. We'll assist you in, we've got a CRM that's got AI built in that will follow up. We'll send out the reminders, get the patients to engage, get the patients to self-book. It's all part and parcel to what we do. It can be just as beneficial, just as profitable for a complete startup.
Okay, so that's good news. So whether I have existing patients or not, it still works.
Yeah, the program, from a standpoint of an ROI on the package that the cost in order to do this, the ROI is very quick. And you cannot, with our financing setup, it's easy to implement this program on minimal costs and get it going right away. Tom's program on what he does, how he trains, all that stuff is down pat. And basically we start, once you get set up, you get your pumps and then it's right into training the mid-levels and the MAs on how to continue, provide the care. And then it's right on to the next step. And then it's just basically putting the package together, implementing, we show them if you don't have ANS testing, we'll help you get that device and be able to show you how to utilize that. We'll help you set up punch biopsy setup. Tom will walk you through, the best glucose monitor to get, how the diabetic counseling works. So the whole thing is, like I said, it's a turnkey program from start to finish.
That's awesome. And so we have a link that we'll place beneath this video where people can send in information and have you reach out to them and see if this is something that would be good for them. Is there any other criteria or anything that you would want to have any of the listeners know before they would reach out to you?
Well, from a business standpoint, we work with integrated practices. I'm working with, I've just I started working with an 11 location pain group, right? We're doing anything with, probably 4,000, diabetic and neuropathy patients. And they're just basically doing the traditional stuff. I showed them this program and they were like, oh my God. So now they're setting up a separate clinic that's basically referring those patients over to now treat them this way, right? On top of what they do with their pain and all that stuff. So it does not matter how big you are. If you're not doing some of this stuff, and if you're not having that, setting up like a clinic that you could see those referrals to those patients that are going to benefit from this. So from small to big, we've dealt with a lot of different size practices. And it's, like I said, it's incredibly great if you got the patients already. But we can show you how to get there with Tom's marketing, because Tom went from 0 to 60, right? He went through the bumps and bruises. So he knows exactly what you're going to go through from a startup. So he's already worked out those kids, right? And so now he knows exactly. So now he's got the videos that we're going to be able to show these guys, your newer clinics that are saying, hey, I'm an integrated practice. I have the staff. I have the want, right? And so I just don't have the know-how. So Tom's going to be able to come in and show you, exactly how he did his marketing to get you up and running. But now you can go right away, right? Now you're able to just basically take those videos, take the marketing material. We already have a marketing group that you can work with that you can just turn you on, and then you can basically go right away. So it's going to, we already worked out the kinks for you. So all you got to do is turn it on. Right.
Nice. That's exactly what people need is to, because the learning curve is huge on these things. Most people that are, already physicians are already busy. So basically I can just reach out to you or work with your program, either give me new patients if I need them, or I can use my existing patients, but everything's figured out and it's executable. And the best part is I can just manage it as a physician and have, my staff basically execute this. And I'm going to make amazing results for patients. I'm going to basically improve their A1Cs, especially their fasting glucose, which is a huge monitor, a huge metric. And then also you see that it's improving their kidneys, their quality of life, giving them decreased medications, improving their neuropathy. I mean, it sounds like it's a win-win all the way across the board. You get paid pretty decent, from an insurance for it, but also get to help people, and it plugs right in. It seems like it's a great fit.
Yes, it is. That's a perfect summary. But from a business aspect, what we've eliminated is two sheets. Fear of getting audited, right? You're prepared with what we show you how to do. You're going to be prepared to get a question from a Medicare or a Blue Cross or something. So the fear of getting audited, we're going to take that out. Compliance is number one. We're going to show you how to be very compliant. And two, the fear of startup, getting into this program without the knowledge and knowing what was going. We eliminated that fear because we've already worked out all the kinks and we have everything for you to all you got to do is follow it and then you're ready to go. I mean, so the fear is kind of laid by the two things that we've done, and that's compliance and setting up the marketing and already working those kinks out for the marketing aspects.
Well, man, that's huge. Well, guys, thank you so much for coming on the podcast. And if you want to find out more information and basically, have Paul or, have Paul reach out to you or Tom, go to insulinhero.com and fill out the form, and that information will be sent over to Paul, and he'll be reaching out to you to answer any questions you have and find out if this is the right program for your practice and something that you can add on or maybe start a new practice using this technology.